In this section, we're going to talk about disorders of the nervous system, particularly of neuromuscular function. So the basic component of the neuromuscular system is the neuromuscular junction. So this is the area where a nerve ending or synapse meets a muscle fiber. Right? The space between them that we need to transmit the impulse of our contraction signals to is known as the junction. Right. The neuromuscular junction uses acetylcholine to transmit that signal between the nerve ending and the muscle fiber. Acetylcholine binds to receptors on the muscle fiber, and this is what triggers them to contract. Acetylcholine is responsible for muscle contraction. If we have imbalances in this, then we're going to have issues with muscle contraction. Acetylcholinesterase is the enzyme that we use to balance and break down acetylcholine when we have too much of it. Myasthenia gravis is an example of a problem with acetylcholine receptors. Right? So this is an autoimmune disease. What happens is that our antibodies in these patients, for some reason, start to break down our receptors for acetylcholine at that neuromuscular junction. It's 3 times more common in women, and it peaks usually at 20 to 30 years old. Patients who have myasthenia gravis also have some type of T cell dysfunction usually. About 75% of them also have thymus abnormalities, which is interesting since that's a lot of times where we rely on to mature our T cells. And they may even have tumors known as thymomas. So what happens is then over time, these patients have fewer acetylcholine receptor sites on their neuromuscular junction. The fewer the sites, the harder it is to trigger a muscle contraction. So their muscles fatigue very easily and wear out. What happens is that early on, their first symptoms are related to our fine muscles in our face. So they tend to have issues with periorbital muscle movement and eye movements. They may even have problems with ptosis or diplopia, the drooping of the eyelids. They could have problems with their facial muscles making expressions like smiling. And then as it progresses, it's going to move on to issues with their extremities as well. And then in most severe cases, it will cause failure with the respiratory muscles. So when we're talking about the neuromuscular junction in myasthenia gravis, right, so this is our nerve endings, this is our muscle fiber, right, acetylcholine means the chemical mediator that causes the contraction to occur. In myasthenia gravis, for some reason, an autoimmune response causes the antibodies to attack those receptor sites, so then acetylcholine is not able to bind and cause contraction. This is just another diagram of that space and how the antibodies in myasthenia gravis will block the receptor sites and damage them. This is a picture of the ptosis, or the eye drooping that can happen. Okay. So patients with myasthenia gravis, what happens is they have their best muscle strength in the morning. And then as their day goes on, their muscles get weaker and weaker, especially the muscles that they have used repeatedly throughout the day. That's why we often see it first in our face, in their facial expressions and eyes, because you blink a lot more often than, for instance, you always have to walk around. What happens then is we are at risk of these patients having crisis events. So myasthenic crisis would be when we have an undermedication of anticholinesterase medicine, right? And there's not enough acetylcholine available, so then we have no muscle contraction. A cholinergic crisis can happen if we over-medicate them and we cause the opposite problem, where we give them too much acetylcholine and then their muscles contract to the point of exhaustion and can't let up. The next concern with our neuromuscular problems is peripheral nerve disorder. So now we're talking about nerves in our arms and distal circulation, legs, things like that. If it's one nerve that's causing problem, we call that mononeuropathy, right? It's localized to one nerve condition. For example, maybe somebody fractured a hand or an arm and they pinched a nerve, right, and compressed it. Right, if there is ischemia to a nerve, that can cause a problem. Infections can do this. For instance, shingles is whenever the herpes zoster virus has infected one single nerve tract. A common problem that's a mononeuropathy example is carpal tunnel syndrome. This is where we have compression of the median nerve that goes down the wrist and into the hand. It's characterized by pain, paresthesias, numbness and tingling, particularly at the first two fingers and thumb, pain in the wrist, and then eventually their grip becomes weaker. So mononeuropathy, carpal tunnel is the example. This is the median nerve. What happens in carpal tunnel, when that median nerve passes through the carpal space, it gets compressed and pinched, and that leads to the symptoms the patients feel. Now we can also have polyneuropathy. Poly means many. Alright, so in these disorders, there's going to be multiple or many various nerves that are impacted. Things in this category include demyelination disorders or axonal degeneration of multiple nerves. Right, this leads to symmetrical sensory and or motor deficits. An example would be Guillain-Barré syndrome. So what happens in Guillain-Barré is that after some type of fairly benign infection, it triggers an odd immune response, right? The antibodies after the infection, when they then start attacking the nervous system, right? This results in segmental demyelination and edema of the peripheral nerves. And then eventually that means the muscles don't have signals going to them. Okay. With this disease, what happens is that they have ascending paralysis. So that means it starts in our lowest extremities in the feet and legs, and then the paralysis moves upward through the body. The patients will have numbness and tingling before they have paralysis, and then they end up with complete motor loss. So this is just an infographic if you're a visual learner. Patients usually just have some type of common, not too drastic infection, such as an enteritis or a GI bug, right? And then they'll notice after that starts to subside that they're having trouble in their feet and legs, in their hands, in their distal circulation, where eventually they just have numbness and tingling, and it progresses and goes upwards to cause paralysis. And then it's a severe condition when it hits our core and affects our respiratory muscles. These patients could require hospital stays in the ICU for ventilator support, right? But the key is that they have to try and calm down the antibody response. So they may have to do plasma exchanges or give them immunoglobulin to try and get rid of those antibodies that are attacking the system. There's also disorders of the basal ganglia in the brain. Parkinson's is a common example that people think of for these disorders. What happens in Parkinson's disease is that there's a degeneration of the dopamine-producing neurons in the substantia nigra of the midbrain. This disrupts the dopamine-acetylcholine balance in the basal ganglia. So we need acetylcholine to cause muscle contraction. Dopamine's job is to balance it out, to make our muscle movements nice and graceful and fluid instead of jerky and rigid. Right? The imbalance where we have too much acetylcholine and not enough dopamine then gives us a triad of the classic symptoms of Parkinson's, particularly tremors, rigid muscles, and bradykinesia. When we're talking about the substantia nigra, we're talking about here in the midbrain section. If we do a cross section of somebody's brain, that's where it would lie. Right? This is what a normal, healthy substantia nigra looks like. What happens is that the degeneration of the neurons, you can see they're much lighter in somebody's brain who has Parkinson's because they're not working, they die off. So in normal muscle contraction, right, we have our neuron and we have our acetylcholine and dopamine, and what happens is that they bind to balance out our movements. For someone who has Parkinson's, they have much less dopamine, and then what we get is movement disorders. Right, so most patients are diagnosed after 50, and usually between 60 and 70 years old. Men are more commonly affected in a 3-to-2 ratio. We don't know the exact cause. We see an increased incidence in patients who have had a history of brain swelling or encephalopathy, genetics and family trees, illicit drug use, especially stimulants, because what happens is to trigger a euphoric sensation or getting high. These meds often cause a large release of dopamine and can damage dopamine receptors. Patients who've had to have antipsychotic medication use, head traumas that maybe have damaged the midbrain area, exposure to chemicals like manganese or copper, and then sometimes we just can't find a cause. We don't know, especially in younger patients who are diagnosed before the age of 50. Alright, so the symptoms patients experience. They're going to have tremors, and with Parkinson's they're at rest. So that means they're calm, relaxed, may even just be sitting there, and they're going to have muscle movements or tremors. Some of them are even described as pill rolling. It's like they have a little pill between their fingers and they're rolling it back and forth between their thumb and 2 fingers usually. Whenever they have tremors, they usually start off on one side and then they'll progress over time, and they'll have tremors consistently. There's a video here to talk more about tremors if you're interested. Their muscles are often also rigid. They'll have jerky cog-like movements, so like a ratcheting kind of motion. They usually have a very short, shuffling gait where they take tiny steps and don't really pick up their feet. This puts them at high risk for falls. And there's a video here if you want to learn more about their gait and see a video example. Bradykinesia is where they have problems initiating their movements. They're slower. So they know that they want to start walking, for instance, but because of their disorder, it takes longer for that signal to get processed through their brain. So it takes longer for the motions and the initiation of movements to start. Okay. They're also at increased risk for problems with their reflexes because it affects their autonomic movements, such as blinking, swinging their arms, even swallowing their own saliva, and their facial movements are often decline. So eventually, as the disease progresses, they have problems showing expression on their faces. So as it goes on, you're going to have worsening function of the autonomic nervous system. This can lead to problems like orthostatic hypotension, dysphagia, constipation, even urinary incontinence. Later on, it can also lead to dementia late in the disease. Michael J. Fox has a foundation, since he's been diagnosed with Parkinson's, to help with research and give treatment options to individuals. You can see here early in his career as Marty McFly in Back to the Future, right? And then as it's progressed, look at how much less facial emotion he's able to show. These patients will sometimes have what they call a mask-like appearance. This is just an image of a patient or an infographic to give you a visualization of what these patients look like. Next up are motor neuron disorders. A common example people think of is Lou Gehrig's disease or ALS. Maybe you participated in the Ice Bucket Challenge to raise awareness for ALS a few years ago. When we break that word down, you can see how we come up with the name. So basically in ALS, our muscles don't get enough nourishment, so then they can't move. Right? Common onset is between 40 and 70 years old. Most patients are around 55 when they get diagnosed, and men are affected more than women in a 2-to-1 ratio. If you ever read the story Tuesdays with Murray, is about a college student who was experiencing or watching his professor have ALS. Next up is, we're still talking about ALS. So it's rare and it's a progressive genetic disorder. It's going to continue to worsen over time. For unknown reasons, the motor neurons in the brainstem and spinal cord break down, so they don't stimulate the muscles. The muscles don't get used, so they atrophy and waste away. Voluntary muscle action is affected, right, and then eventually it's going to lead to paralysis. Most patients die within 5 years of their first symptoms because we don't have a cure. They see some links genetically, but we don't know what causes it. Alright, we'll pick up next to finish this one out.